this is going to be a bit of a double act. Regina, I know that you work for Health Poverty Action and know that you're actually from Sierra Leone. But do you want to maybe say a little bit more about you, your background, and then kick off with your presentation?
So, hello everyone. It's really interesting to see quite a full room. We're expecting quite a small number, so it's good that people are actually interested in understanding a bit more about Ebola. So my name's Regina Bashtaki, and I'm the country director for Health Poverty Action in Sierra Leone. In Sierra Leone, the Health Poverty Action program is mostly around maternal health and the empowerment of women. So a lot of the work we have been doing has been around community empowerment. So although we work on the 3D loan model, which is we strengthen the hospitals, we work on the referral, the bulk of our work is working with communities to see how they can come up with solutions to their own health problems. So I'm just going to give a short presentation on the actual Sierra Leone health system, and then you can ask me questions about Ebola and also how Health Poverty Action has been responding. So yeah, I'm sorry about those people who have to stand up. I hope you can see. Okay, so for people who don't know very much about Sierra Leone, I'll talk about the location, just some key statistics so you get a sense of how the health system is, and how it's organized, how it's funded, which is quite important in the sense of understanding Ebola, the health workforce, a little bit about traditional beliefs and practices, which I think all of you will know if you're in this room, have influenced the way the virus has spread. And I will show just a little bit about where it is happening in the country. So that's Sierra Leone there on the west coast of Africa. You know, when I say I grew up on the beach, I literally grew up, you know, the Atlantic Ocean is on my doorstep. And it's a really, really amazingly beautiful country. So a lot of the time, I spent quite a lot of time here in the UK, and in sort of like, you know, my 20s and my 30s, we got into all these holidays. Oh, let's go to the Caribbean. Isn't this place so fabulous? And I'll just tell about this place, and I'll be thinking, like, where's the beach again? Because really, literally, I grew up in a place that the beaches were so amazing and so unspoiled. So the country itself is divided up into 4 areas. So there's the north, east, south, and west. And you see this tiny western area here. This is kind of where the capital, Freetown, is, and the western rural and western urban. But that, so it's a 6 million population, but after the war, a lot of you know, we had the 10-year war from 92 to 2002. After that war, the population in this area has tripled. So it was about 500,000 before, now it's about 1.5 million. So the infrastructure is just not ready to cope with what's in it. And it's just a very tiny part of the country. So it's 6 million people, quite a low life expectancy, so 45.3. Adult literacy, it's about 43%, and actually that's increased quite a lot in recent years. So, you know, for a lot of the time, the illiteracy rate was about 70%. Maternal mortality ratio, as per DHS, this 2013 is 1165. So I'll say, for instance, you know, so that's how many women die per 100,000 live births. In the UK, that number is 8. So, you know, to get a sense of what we're talking about, it is quite a weak health system. Under 5 mortality rate, this is something, it's 182. Again, this is something that, honestly, for people who've been working in Sierra Leone for 10 years or more, they'll tell you about the gains that we've made in this. Population using improved water sources is 60%. So, you know, the people who've been doing Watson work in Sierra Leone have been doing quite a good job. Improved sanitation is only 13%, so open defecation is still very common. I'll just give you a little example of some of the maternal health work we've been doing, and people have been thinking, well, you know, what do women do for sanitary pads and things like that? Why don't we put them in baskets that we're selling out in the community? And, you know, go out and say to people, yeah, so what you need to do is use them and then put them in your toilet. Just, I don't have a toilet. Yeah, so, you know, just to get a sense of what we're dealing with. And yeah, poverty ratio is still about $1.25. So, how much is the government actually spending on healthcare? So that's shown down here, and you'll see that, you know, we've hardly ever spent more than $10 per head, and the recommended amount is about 55. I also know that being in Sierra Leone, a lot of the time, even these budgets that are used here, they're hardly ever always transferred. So, you know, it will be on paper, but actually when you go down to the districts, or when you be like, oh, we haven't received this money yet. So some of you may also know about the Abuja Declaration. So this is a meeting that was held by African head of states in 2001. And at that, they pledged that to try and meet MDGs, they'll spend at least a minimum of 15% of their total budget on that. So that's how we've been doing. So although we're spending quite a small amount, it also is that our budget is quite small. So the actual money that the country collects for varying reasons is very small. So no surprise then that a lot of the money to pay for healthcare comes out of the pockets of those people who have just told you average about $1.25 a day. So, you know, about 75% of it still comes out of pocket. One of the great things that have happened in healthcare, while I've been working in Sierra Leone, has been the free healthcare. So 2010, free healthcare for pregnant women and lactating mother and under fives. Honestly, when I started working in 2008, we would be running around. There were so many initiatives we were doing. Health Poverty Action was really acclaimed for this wonderful loan scheme that we had. So, you know, we put in ambulances and things like that. And then we had this community loan schemes where people would literally, you know, if you were sick, somebody would almost just authorize a loan very quickly. In fact, we had arrangements with hospitals where they would see if somebody lived in a particular place and you turned up, they would just treat you, and then, you know, later on the whole process of the loan would be sorted out. That was making a really big impact, we thought, until 2010. You know, when governments take things on and do things in a big way, I mean, it was like everything we had been doing was just so small. You know, utilization just went through the roof. And then it came down again, and not right back down to where it was, but steadied. So that shows you that really, you know, universal services, that's the thing that actually makes a big difference long term. So the health workforce. So we've got about 2 physicians per 100,000. You know, the other day I was talking to colleagues in Pakistan, and it seems like, I don't know, they have something like 1,400. They just train so many doctors in Pakistan. They have more doctors than nurses, I think. Midwives, so for every 1,000 births, only about 1 is attended by a midwife. So the others, the bulk of people are what we call MCHAs. So they go through a two-year training done within Sierra Leone. And we've got about 6 dentists in the whole country. And the saddest thing is, and I think it's up to 6 now, 6 doctors have already died out of the 120 or so that we have, and about 80 health workers. And, you know, the health workforce, it's like 2,000 and something. So it's really a significant dent, the number of people that have died in the Ebola outbreak. I want to talk a little bit about traditional beliefs and practices, because I think that also impacted quite a lot. So when the Ebola outbreak started in Sierra Leone, I have to say, you know, I was in Sierra Leone in March when the outbreak started. We were all going, in Guinea, we were all going to Ebola preparedness meetings. All the donor agencies were there. Who was there? Everyone was quite ready. Just tell us what we need to do and we'll do it. Again, even in May, when the first cases were announced, we're feeling like, okay, yeah, we've been thinking about this for 6 weeks. We kind of know what to do. So with health poverty action, for instance, as soon as it landed, one of the first things that we said was, okay, we know exactly what's going to start happening as soon as people get ill, because we understand that in the community, they're going to go to their traditional healers. And because we understood that, we started going out and training traditional healers wholesale. Honestly, in retrospect, I wish we had not waited until the outbreak even came into Sierra Leone. I wish we had, in March, started doing that and going around. But, we all didn't know exactly what. So here's a picture of a traditional healer and some of the things that they've been saying to us. When we trained them, we said to them things like, okay, so what illnesses have you dealt with before, what symptoms? They will describe all of these symptoms to you, and they felt like, yeah, we're quite confident that we know how to treat this and treat that. And then we had to explain about Ebola, and honestly, they were really surprised and shocked. This person here was saying, okay, I will just take the lead in trying to tell other people. We had traditional healers who, as you can imagine, are quite hated by the health workforce because they make their lives difficult, they do the wrong things and all of that, and then they end up with them, with the health care workers. But the traditional healers, after this training, were actually asking for meetings with their local health workers. They were saying, can we have a meeting so we can organize what should happen? They even said to us, look, it's the drivers of the motorbikes, the commercial motorbikes. They are the ones who bring the healthcare workers to us. Can you give them some protection? Hearing what you've said, we really need, so, they were telling us exactly, and that's exactly how health poverty and action has always worked. So again, some other traditional healers just saying, I just did not know that this is possible. So, and in Sierra Leone, there's a very strong belief in God, and a strong belief in spirituality, and people, that's our starting place. So, this person is saying, I thank God that I've been able to access this training so I can. And I put this picture up there. That's actually a stock photo, but poverty is so much like, young children, they will pray in Sierra Leone, but when they pray really just like, I just hope my mom will get enough money today so that we can eat. That's the kind of level that, when children pray, it's about those very, very practical things, or that I'll have enough money to pay my school fees, for instance. They worry about that a lot. So, this is the final slide. Just wanted to show you about kind of, the Ebola outbreak and where it was now. So I've put in Liberia and Guinea so you get a sense. I think this is at about 31st of October, and this is a slide from WHO. So you'll see there, I explained to you about how dense Western area is. So it's no surprise how quickly the virus is spreading there now. We all knew that was our first starting point. We really, really need to try and make sure that it doesn't get to Freetown. If it gets to Freetown, it's going to be so bad. And unfortunately it did, and it is so bad there. I think that's kind of all. I had just a quick message, since I know that if you're in this room, I kind of feel like you're on side. So I say donate if you can. Understand how Ebola is transmitted and try and educate others. In the time I've been in London, people have asked questions like, oh, okay, so when did you come back from Sierra Leone? And I can see them mentally calculating the 21 days. So I would say up front, so I've been here from, and without, or, other people would say things like, oh, have you had anyone visit from Sierra Leone recently? And, I can't say that I blame people, but I'm also thinking, this is kind of not what I want to be dealing with right now. And finally, if you're a healthcare worker and you can volunteer to work in Sierra Leone. So thank you very much for your time.
Thanks, Regina. I know this is supposed to be a workshop. We're definitely going to try and make this a workshop so we have some conversation and interaction. But I was asked to complement Regina's talk by referring to some of what I wrote in a blog. How many of you read the blog, just out of interest? One, a few. And what the blog was trying to do was to talk about Ebola not from a health perspective, but rather Ebola as a social phenomenon. So if I can very quickly run through what the argument is, apologies to those who've already heard this by reading the blog, but a couple of things about Ebola. The first thing is it's not new. This is not a new virus. It's been around for decades. The virus hasn't mutated or evolved substantially. But what seems to have happened is that the conditions to enable an outbreak to turn into an epidemic all came together. The second is that Ebola is eminently controllable with basic public health measures. There is no carrier status. You are only infectious when you're symptomatic, so there's no situation where you're asymptomatic and infectious, and it's not airborne. So with relatively good public health measures, you should be able to control Ebola. So the notion of Ebola being a threat of any sort to health in England is clearly unfounded. There are two things that are required to make Ebola controllable. One is a functional health system to be able to implement these public health measures. And we've heard from Regina that Sierra Leone does not have a functional health system. It's got a decrepit, broken health system. It's under-resourced, but it's also fragmented. It's broken up into a whole bunch of multiple small programs and projects, disease-based programs, projects run by many different NGOs. There's no coherence to what exists in Sierra Leone. So it's under-resourced and it's fragmented, inefficient. So the hopes of controlling something like Ebola, given that situation, are quite small, quite minimal. And of course there's problems with infrastructure, with communications, transport, roads. The second ingredient that you need is trust. Trust is important because people need to believe what they're being told about how to respond to Ebola, what the symptoms mean. Trust is required in terms of contact tracing. And in Sierra Leone and Liberia, less so in Guinea, trust is, there are extremely low levels of trust for obvious reasons. These are countries that have been ravaged by war. These are countries that experience large amounts of exploitation and huge degrees of inequality. As I mentioned earlier, Liberia, Sierra Leone are wealthy countries in terms of their natural wealth, but incredibly poor. And one of the reasons is because there's a large amount of exploitation and resource extraction. And in fact, both Sierra Leone and Liberia have been two countries which have seen the largest amounts of what's been called land grabbing, which is a phenomenon that took off after 2008, linked to the financial crisis. But there's no accident that Sierra Leone is occurring. This epidemic is occurring in countries which have experienced land grabbing and years of exploitation of natural, particular mineral resources. The land grabbing is relevant because land grabbing has also resulted in changes in the ecology in places like Sierra Leone and Liberia. So deforestation, planting of oil palm in particular, has meant that the flight and feeding patterns of the fruit bat have changed. And the fruit bat is the primary animal reservoir for the virus. So the interaction between humans and the fruit bat have changed as a result of changes in the ecology. And that's been one thesis as to why the virus has taken off now in Sierra Leone and in Liberia, in West Africa in particular, having previously been mainly in other parts of Africa. So these are really all social, political and economic pathologies that have led to a health crisis. The other thing that's, I think, interesting is this notion of crisis, what Thomas was talking about earlier. Constructing Ebola as a crisis. And it is a crisis. If you're a Sierra Leonean or a Liberian or a Guinean in a village, confronted by this frightening and and scary disease. But the notion that this is a crisis for the West, that this is a global crisis, needs to be challenged. Why, I don't think it's a crisis. I mean, I think there are other crises, but Ebola is a global health crisis. I don't buy that. Not to say that it couldn't kill people in the West or in the North, and not to say that Ebola isn't a dangerous and frightening disease. It is. It's not a crisis that will threaten to kill large numbers of people, because it is controllable. So one of the things that some academics are looking at and studying is, well, why is it? Why did it turn into a crisis? What's the reason for this? Is this a crisis that was generated by the press, mainstream press? They like a crisis. A crisis is always good for selling newspapers. Is this a crisis that was drummed up by health agencies? It's only when it's considered to be a crisis for the West will the West then pay any attention to what's going on in Sierra Leone and Liberia. So maybe there was a need to drum this up as a global crisis in order for there to be resources allocated to West Africa. But there are many other groups that will benefit from the crisis. Pharmaceutical companies love this. They love the fact that this is a global crisis, because the global crisis is such that the solution to this crisis is new vaccines and treatments for a disease that's existed for 40 years that is controllable. So they're getting huge, huge public subsidies now for the development of vaccines and medicines, a bit like with the SARS virus. You saw, again, history will have to tell us whether the same thing will repeat itself, but we spent large amounts of funding on Tamiflu during the SARS crisis, which turned out to be a waste of money. The security complex loves this crisis. They love it. Border agencies, companies that provide security, people that provide scanning equipment so that you can detect people with a temperature as they walk through the passport control desk. Large amounts of money are being poured into the jacking up of security apparatus on the back of Ebola. The military, we've seen really frightening examples, I think, of the military being deployed in uncritical ways. And also what's interesting is the way the military has been deployed along old colonial lines. French military in Guinea, the Americans in Liberia, the Brits in Sierra Leone. It's quite extraordinary how that's transpired. And then similarly, I guess there's this idea that the West is saving Sierra Leone and Liberia, when you could argue that the West has actually been exploiting Sierra Leone and Liberia for decades. So there is, again, the possibility to benefit from this crisis and respond to the crisis. That isn't really being represented in the mainstream media. The only other point to talk about is in terms of global governance. There's a lot of discussion and soul searching going on now about the failure of global governance for health. Because the one thing that WHO was supposed to do was to be able to implement the International Health Regulations, which is a set of international laws designed to control communicable diseases across borders. And WHO has been weakened for many, many decades, underfunded, under-resourced. But everyone agreed that they must be able to control communicable diseases. That was one thing that they wanted WHO to be able to do, and they failed. And clearly there's been a failure of WHO, particularly in the African region, the AFRA office. So that's another thing that's emerged from Ebola. So the point of Ebola, I think, it talks to the work that organizations like Health Poverty Action do, HPA are a community-led, community-based development organisation who trade on trust. They work with communities, they build with communities. And it's these organisations that are going to be much, much more important in addressing Ebola as opposed to the US military. Because trust is such a critical ingredient, and there's a possibility that the overuse of foreign military in these countries may only undermine the building of trust that's required to manage Ebola. But the second thing about Ebola is that I think it kind of highlights why Medact has this very broad agenda. It kind of links the economic, political, ecological issues together. And even the war and conflict. I mean, the amount of money that's spent on the arms trade in both these countries, it really makes your eyes want to water. But again, that fuels mistrust, miscommunication, internal conflict, all of which fuels the spread of the virus. So that's what we wanted to run this workshop on, and I know it's kind of turned a bit into a lecture, but it'd be really great to hear your thoughts and ideas about Ebola, how we can use it in a positive way. Thanks. So let's open up to any comments or questions from the floor. Yeah, Jeremy, and then Frank, and then we'll go again. Should we take groups of three? Comments and questions, yeah.
Just picking up on that point about trust. I mean, it was said 4 or 5 weeks ago that actually the British Army were the only group or the only organisation that was trusted in Sierra Leone, and therefore it was necessary for the army to go in to establish some of the infrastructure that is so manifestly lacking. So whilst your thesis of trust is really important, I'm sure it's right, we need to reflect on the fact that actually some of the organisations that you're then criticising are ones that are trusted. And maybe Regina's got a comment on that. Yeah. The other observation or question really is how is Health Policy Action working with other aid agencies like MSF? Because MSF is the one that's getting more airtime in this country is being active at. So is there trust between them?
My question is more to you. It's about the funds that are being raised. I've tried to sort of trace down in Google where the funds that the WHO are appealing for, how they're being distributed. I mean, is there any conditionality to it? Are they going to the NGOs? Are they going to the governments? What are they being used for? Are they going to the pharmaceutical companies to develop the vaccines? There doesn't seem to be any information on where that money is going.
My point was going to be that Ebola isn't the first example of a tropical disease that's been neglected by the West until there's some perception of crisis. I mean, malaria classically. I mean, this hospital is associated, this school here, very much associated with the attempt to develop malaria vaccines. And in spite of the brilliant work of Brian Greenwood, it's scarcely off the ground, largely because it's just not of interest to Western pharmaceutical companies. So I think that's an important point. The other little thing to say is that by profession I was a blood transfusionist, and one of the so-called drugs that's been moved to this is post-infection plasma from people who've been infected with immunity. It's actually very easy to get such stuff. But the pharmaceutical companies will then make a meal out of the whole process of refining that to meet world standards. And some time ago, I was a co-author of an article in the Public Library of Science about blood transfusion standards of the West being totally inappropriate for that of developing nations. And I think that's a point that should be borne in mind.
Maybe let's take another 2 more. There was a hand there and a hand here.
Hi. To see whether you wanted to project forward to when Ebola is no longer an issue for the 3 countries, and what you think will be the impact on the health system of Sierra Leone. Will it have been strengthened by the influx of emergency hospitals and health staff, etc., or will it have been sort of further decimated?
It's really a question to Nadine, I think. One of the trade-offs of the natural resource exploitation has been that the Chinese have built some rather splendid roads up into the east of the country, and particularly up to Kenema. It's now a very fast road. And I wonder if that has played a part in the spread of the virus down to the west. That's the first point. And the second point, very briefly, is a rather sort of sad point, but certainly it seems to be creating work for some of the young men and women in the country who haven't been able to access any employment at all, but are now able to running the mobilisation centres, running the burial teams, and are certainly getting a role in the community and a status in the community that they mightn't have had before.
So, as a positive.
Well, a horrible positive,
Yeah.
but nevertheless.
Yeah. Okay. I mean, on the issue of trust, it is true that the trust in the government is probably less than trust in British troops in Sierra Leone. So that point is taken, but maybe you want to comment on that, Regina, and also about the question about the money.
So I think on trust, definitely it's very important. The biggest people, the biggest agency that the Sierra Leoneans don't trust is their own government. So it's much the same debate as we're having here, really. You know, when Ebola first started, people were saying, "Oh, don't worry, it's just the government trying to get money from donors. There's nothing happening," and that was from very well educated people. It was understandable. So yes, and the British Army, they've been there in the war. There's still the IMAP base there. So yes, they are trusted. I haven't been there once while they've been there this time. So I don't know about kind of any emerging issues or anything, but the money. Okay, so when the whole outbreak started, there were quite a number of task force set up. So there's like a communication task force, a treatment, and so on. And budgets were set up for everything. So there is actually a national budget. So when WHO raises money, it's directly into that. If you give money to MSF directly, again, MSF would have been factored into kind of treatment, how much is needed, and that would go directly into the treatment center that they run. How is Health Poverty Action working with MSF? So MSF run a treatment center, essentially, but there are many elements to the whole response, and Health Poverty Action has been more on the social mobilization. But I have to just answer very quickly and say, actually, because this is at a scale that all of us did not imagine at all, more and more agencies are having to do more. So, I sat up yesterday trying to write a proposal then that's going to support a hospital to set up an isolation unit and its treatment. It's the sort of thing that we wouldn't do before, but we really just have to think now, let's do something because something needs to be done.
I mean, on the issue of what happens after the crisis, there's an opportunity to address all these pathologies, social pathologies, economic pathologies, hopefully. Whether the health system will be strengthened long term or not, I don't know. But interestingly enough, China has been heavily criticized for not responding to this emergency problem, and that they have actually said very explicitly and clearly that they are intending to make a long-term investment afterwards to strengthen the health system. Whether or not they will or not is unclear. Sierra Leone, 40% of its expenditure comes from external funding, donor funding, Gavi, Global Fund, World Bank, DFID. These are big agencies. So there's got to be a question mark as to what has gone on for the last 10 years in terms of proper health system strengthening. And have they contributed to the fragmentation? Have they actually invested in long-term health system strengthening, or have they just been focused on short-term disease control, HIV, AIDS, TB, malaria? And hopefully this will be an opportunity to honestly reflect on mistakes that were made in the past. I think roads have played a role, mobility, but I think my understanding is that it's been burial practices plus hospitals inadvertently being the main drivers of the epidemic. So a poorly functioning hospital is in some ways worse than an absent hospital when it comes to Ebola. But yeah, if you look at the map, then it's clear that it's gone all over the place. It must be through road travel.
Just to pick up on the point on absent hospitals, now that's one of the biggest problems that we're facing. So now in Sierra Leone, if someone dies, the corpse has to be tested. So the corpse gets tested. If it's Ebola, then it's done, given an Ebola funeral, and if not, then it can be returned back to the family. And a few weeks back, about 3 weeks back, they tested 87 corpses, and only 25 of those were Ebola positive. But what's happening is a lot of people are dying of other diseases because the hospitals are not there, and that's the big problem that we're facing now as well.
I mean, some hospitals have been completely shut down.
Just completely shut because, you know, your doctor said, I don't know what to do. So, okay, let me just shut it so I don't make it worse. But again, now people are, you know, we're getting, say, used to it, but we're understanding that we need to do more. So we're trying to explain.
Another random, yeah.
It's just about how you think that it's going to be possible to build trust in the hospitals again afterwards. I worked in the Children's Hospital and there now, I think it's 175 beds, and there were only 30, last week there were 30 beds that were full. And there is a holding unit being built down behind the hospital, but people aren't going to, not going to trust the holding unit, and the speed of getting the results back is still a problem, and the hospital remains empty.
Why is it that health workers weren't trusted? So, I mean, there's so much mistrust of health workers. What was the reason for that?
Well, health workers in the health system basically have always been kind of poorly trained, ill-resourced. So the work that we do with, say, traditional birth attendants in rebranding them, for instance, is all based on the fact that people trust these women in their community more than they would the health workers. It's about training for the health workers. It's about, you know, how they deal with patients. To some extent, not too different from the NHS. So for those of you who work here, you know, with kind of how you, if you feel comfortable and you feel that your health worker has your best interest at heart, really. Other things also have been around kind of charging. So all through there have been issues around maybe whether this is free or this is not, but that the fact that the health worker is more interested in getting money from you than they are, you know, in actually your care. So that those are the things that have been at the back of the minds of people in terms of, you know, trust.
Do you have any thoughts about how trust can be rebuilt? Or based on your clients?
Absolutely no. But I think one of the legacies about training health workers has been because of the war, that there were a whole generation of people who were going into nursing, but who were going in with really very low educational levels, and trying to build up a workforce from a very low starting point. And it takes almost a generation to push those levels up. You can't do it overnight. And that's where I think the question about strengthening health systems is such an important one afterwards, because we're not going to be able to wave a magic wand and do it quickly.
Yeah.
And funders don't work on those kinds of timescales.
Absolutely. And I mean, also you've got to just, the education system itself has to produce the people who are trainable. I'll give another simple example. Something that's quite common in Sierra Leone is kind of, you know, I'll have my nephew or my niece or whatever I know, which is not done very well in school. So I'll say, oh, can you get her into the nurse training program, you know, and that's it. So it's probably the person doesn't even want to be a nurse, but that person is just trying to help, you know, members of their family so that they get into some kind of profession. In terms of building trust, I think it's much the same as everywhere. If you do it and people see results, you know, so if somebody in my community goes to the hospital and they have their baby and they tell me about a good story that it worked, then I may be more likely to go. So, you know, we will do things like we'll do community outreach with the health workers themselves, do more of that. Once you're sure, of course, you've got to build it. Make sure that the clinic is ready to receive people and that they can provide the service when people do come. The other things that we'll do, we'll use the traditional leaders. So, you know, people trust their paramount chiefs, they trust their religious leaders, they trust all of these people. So once we're sure that, yes, definitely this service can be provided, that's how Health Poverty Action will work. We'll engage with them and then they will.
Yeah, just like to comment about kind of the trust in spiritual leaders and such. I was kind of wondering how that role of spirituality and kind of rumors spread throughout Sierra Leone, kind of has that impact on the situation there? Because we say there's trust, there's mistrust between kind of donors and the population, but you know, for kind of a lack of a better way of phrasing this, there's kind of a rumors that they're spread within the population that doesn't allow the situation to get better as well. You know, I went to a talk the other day at London School where someone was essentially suggesting there were conspiracy theories of how Ebola essentially got into Sierra Leone and such. And that really came from taxi drivers suggesting, oh, this is, you know, they brought it in here or things like that and such. So, you know, how big of a role is that? And we're talking about trust between donors and the population, but there just seems kind of a general mistrust within the population as well, I guess. And how do we even handle that? In a sense, you know, how do we educate them for that, where it's a really religious start to it, really?
No, I mean, absolutely. Again, I keep saying this much the same as, you know, conspiracy theories. There are conspiracy theories on everything. You know, Ebola, can't think of anything else, but in the world, that's what people do, you know. And I think that there is nothing wrong with people not just accepting what's put in front of them. You know, who knows that, you know, in 10 years' time, we would not actually learn that actually this wasn't a fruit virus. You know, it was nothing to do with the bat. It was to do with the rat, for example. Because things, you know, do shift and do change. There's nothing wrong with people thinking outside what they've been told. But in trust, really, again, I say it's a simple thing. Trust, if you want to build trust, you have hold dialogues. So once you understand who is spreading this rumor, engage with them. And, you know, have that conversation. Understand why it is that they're thinking that way. What is it that's, you know, that's feeding? Why is it that they want to believe this thing? Why is it a better explanation for them? And that's how you build the messages. So exactly that's how we'll do for everything. We'll just engage with the people, understand it, and then build the messages around that and the actions to follow.
And there are belief systems that are not necessarily rooted in public health medicine.
Absolutely.
In fact, there was a talk, you know, we need to send health professionals, we need to send people to build hospitals, but we also need to send a whole bunch of anthropologists. And that was serious. I mean, and, you know, to understand people's way of conceptualizing this disease. And that was important for more effective communication. So I've got a hand here.
Yeah, I've got a question about global governance, because we are all the time saying that WHO has failed, but I would really like to know, one thing is the funding of WHO, which you can question and which you can like rebuild, have another idea of how to fund WHO, but the other thing is, like, how can you improve WHO on an organizational level? Like, what is needed?
Should we take a couple more questions?
My question is quite related to this. It's so you were working there pre-Ebola, weren't you? Poverty action. How strong is the government or the health ministry there in terms of governance? They're getting 40% of their financing from donors. How much input do they have in how much the money is spent? And you know, did you as health poverty action have to go through a lot of sort of hassle from them in deciding what kind of projects you do, or was it fairly easy to just do whatever you wanted?
I think if you get most of your funds from somewhere, you're heavily influenced by them. But I'll say something that when Ebola started, or even when we had the first task force, there was a young minister in post, and one of the things that she was saying was, okay, this is not going to be like the last cholera outbreak. You know, the ministry is going to be in charge, and we're going to do, you know, everything. There are two things there. The first is that, yes, they had the goodwill to be in charge, but they didn't have the skill. They didn't have the skill and they didn't have the capacity. The second thing, which is a little bit unfortunate, is that our government is quite corrupt. So quite early in those days, you know, you would think, you would look at a group of people and you would know exactly, okay, that they're thinking about this. But you know, the way they've structured this, they've structured it so that it's more about how many trips they can get to go there and how many per diems they can get. So that is a truth. So in terms of how much power they have, they have power, but also the people who pulls the purse strings. But I also have spoken to donors, people who work at DFID, for instance, getting a little bit frustrating and say, telling the ministry to do this, but they're not doing it. So it's not always like, they just say yes to everything that the donor says. For Ebola, they really, so like I said, we had all the task force, and when you were doing something, you had to kind of, just at least inform the task force, and people would look at that. So right now, for instance, I'm on the committee of a game that Cordade is developing, a game that children and people can play in the community on Ebola. And that has had to go to the social mobilization task force. And they've looked at it and said, okay, yes, this matches our messaging, yes or no, those sort of things. But David had already said also that it's quite uncoordinated. So there's still people out there who maybe don't even know the task force exists and who are doing their things in their little corner. Nobody knows everything about it.
In terms of WHO, did I say that WHO failed? Yeah, okay. Because WHO has been failed as well.
Yeah.
It's been failed by a lack of consistent funding for many years now. And the pattern of funding of WHO has changed over the last 20 years from 80% unconditional funding to now 20% unconditional funding. But there is failures within the regional office of WHO which are probably more related to political failings. I mean, there's corruption in the ACRA office. There are the election and appointment of people who don't have the right skills, etc., etc. There are problems within WHO. But I think that you're right, that there are other reasons why WHO has failed, that we shouldn't be just pointing fingers at WHO, because WHO is not a homogenous entity, it's governments plus a secretariat. And the governments haven't really been funding WHO appropriately and adequately for some years. Frank?
Yeah, well, that's certainly the case even in my little field. There's a lot of corruption and vested interest in WHO about how the resources are used. Two other little points. Back on the trust thing, it's not exactly helped when Western politicians take such an irresponsible attitude about people coming to their countries and taking such an exclusive attitude. So that's not helping the trust issue. The other thing I just wanted to ask is hazmat suits or visors and goggles and all that sort of thing. I can't believe that they are actually of much help in the practical situation because they are cumbersome, hot and sweaty, etc. What actually, and I would imagine that their barrier of communication is a considerable disadvantage as well. But that's just me thinking. What's the actual practice out there?
Well, people are definitely using them. I mean, my understanding, so I haven't worked very much in the treatment centres at all, but when I talk to colleagues at the isolation rooms, MSF, they're using them and they're using them a lot.
Yes.
Because that's another problem for the environmentalists, I don't know how it is, but they're incinerating vast amounts of these suits.
Yeah.
But this is a this is a virus that transfers very quickly. So, the people who are surviving, they're being very, very careful. In fact, one of the very first doctors who, we were all so sad to see die, Dr. Khan, actually later on people were saying things like, they didn't have enough suits. They didn't always change after every single, time. And and also when suddenly we've been involved in buying them, and we found that actually, even there's been shortages of, just trying to buy them because nobody expected to be making these suits in that amount of numbers, but they're being used. So I know that also there are people who, when they donate, are kind of wanting tangible things, and to feel free to donate towards that because there are a lot of them being used right now.
Can we make it so that it goes, like, can we make it a sort of a targeted donation just for getting suits and things?
Probably, this is the truth about how NGOs work. It's really hard for us when somebody says, I give you this money and here, use it this way. Because, it's kind of hard to take your 5, 10 pence and put it in this little pot and say, but so kind of just trust that, it will.
I just have a doubt. What's happening now to the survivors? And especially because I, reading and everything, you see that a lot of them are like teenagers, children, and probably most of the family already died. And is there anything in place for the post-outbreak emergency for
my knowledge from the government point of view, I think they've been so focused on just trying to deal with the outbreak right now that there is nothing kind of really tangible that this is the plan. To say that, you know, children are not going to school in Sierra Leone right now. We're spending time, you know, people are listening to radio programs. We're looking at ways that but for people who are asking about kind of, you know, opportunities for long-term strengthening, I see, for example, education, because now so many different players, people who would normally not think of themselves as delivering in education, have to do something because all this very, very young population, they're all at home right now. From September, no child in Sierra Leone has been to school. Can you imagine what that's going to do for the system? So, but a lot of NGOs are doing uncoordinated things right now. That's how it always happens. So we will do something for the little part of the country that we work in. And again, but yes, I mean, the children who have been affected by it and survivors, they're stigmatized. They get the same treatment as people, you know, get when they're here. Everybody is scared for their own safety. So you had Ebola, people don't want to be near you. It's, yeah.
Yeah, I'm just wondering if anyone has done an analysis of how much money the pharma are saving by not conducting their own standard clinical trials for potential vaccines in this area. The subsidies that they're receiving, and then their shareholder, you know, their shares going up. I mean, that would be quite a good way of quashing this concept that's, you know, around everywhere, that this is they're doing this out of good, you know, with their hearts and their generous spirits, really.
Yeah, I don't know if anyone is. It'd be interesting to look at that. Yeah.
Yeah, about the anthropological point of view that you mentioned, what is like people's hopes in terms of this more critical point of view that David mentioned before? Do they really talk about the deforestation procedures? Do they talk about the exploitation that they have been facing all these years, about the health system strengthening? Or the notion that is prevailing is like, hopefully a vaccine will come and everything will be saved, or more MSF clinics. What are they hoping for?
Right now,
Yeah.
I think we're hoping to be out of the outbreak.
But in which way do they think this can be managed?
It will get managed. I feel very much like people think they don't know the answer to it, but that they're open to all the support that the international community is given. So certainly when the British built the new treatment centre, we all agree that it was quite late, but that was, you know, people were feeling comfortable straight away and feeling better, knowing that centre was there. I think also people are just, prices have gone up, things are really hard to get, people are in survival mode. I don't think that they're really, the man on the street is not really thinking long term yet.
Two comments and then Jeremy.
Just wondering if any work is being done to mitigate the psychological morbidities of living through such a nightmarish scenario.
As far as I know, no. I mean, I know that there's been a bit of work for people who are going into, you know, volunteers who have been deployed. The only thing I will say is that it's different. So we had the 10-year war, and if we were to take the same kind of mentality of how you would, you know, look at what psychological support people needed, some of the things that they did very well was kind of do whole community group psychological support, and I think very much that that's how it's going to have to be. So, you know, people who survive, because, you know, on a smaller scale, it's just going to be quite hard, but quite resilient people. We have an enormous sense of, I don't know, like humor that we just keep going with ourselves. So, you know, as soon as Ebola broke out, once we started doing things, we were thinking like, you know, when's the next Ebola joke going to come up? This, because we just know that that's how we deal with things and how we manage it. So, yeah.
Okay, but I'm just going to take two more comments and then we've run out of time. So,
Yeah, I just wanted to touch on when you said previously, the notion of a global health crisis that need to be challenged. So, I think my first question is, what would the alternative be to that? And my second would be, if it wasn't considered a global crisis, and say they kind of hung back a bit, isn't that an injustice in itself, not to be in a community, sorry, in a country that actually depends on donor money a lot, business?
Shall we
Yeah,
and then I'll come back to you.
We hear now that the numbers in Liberia are falling. So are there lessons that can be learned from what they're doing in Liberia that can and maybe are already being transferred to Sierra Leone?
So I've been reading hard to try and pinpoint exactly what those lessons are. I can't say that I know exactly, but what I will say is that in districts where the Ebola outbreak happened first in Sierra Leone, the transmission is slowed down there. So in a way, we've got some of those answers. And we know, for example, like some of the things like bylaws and paramount chiefs. So in Kenema and Kainahu, those paramount chiefs are on those bylaws and they know what to do now. It's just when something's new. And it's a shame that it's such a small country. And when it happened in Kainahu, we hadn't really done everything in Freetown or in somewhere else so that people will know exactly what to do. It's just,
And just on the crisis thing, I wasn't saying that we should challenge the notion that this isn't a crisis, because it clearly is a crisis, but it's how you frame the crisis and how you describe it. It's, to me, a crisis of underdevelopment in Sierra Leone and Liberia as opposed to a crisis of infection. And that will have a different kind of response. So it is a crisis that should be responded to as such. But in what way, I guess? Good. I know we're at 3 o'clock, and so I'm sure you want to go to the workshop. But I hope that was useful. And thanks very much. Which one is it? Refugee. Ah, right. Are you eating?
Yes, you know what the more we think about it, the more it seems to be oh no, it's my current Yeah, I think I'm going to start. So my name's Ina, for those of you who don't know, and I'm not going to ask you to try and listen to my surname. My fiance still doesn't say it in front of me. So I'm going to talk to you today about access to the NHS for migrants and refugees. I understand that this is a slightly selected audience, so you might know a lot more about it than previous audiences that I've spoken to. Just to get an idea of who is here, who of you are medical students? I know a few of you are. Who of you are junior doctors right now? Okay. And who are other types of doctors? Okay. And then some non-doctors. And who feels like they're relatively confident about this issue, about these rules? Any previous interest or experts in the room? Okay, good, because this is not pitched to experts. I originally wrote these slides because I'd done a lot of campaigning about this at the beginning of my medical degree, and then I came into clinical medicine and realised that one of the big things that was missing was knowledge amongst healthcare professionals, and this is not just doctors, but this is nurses, midwives, people dealing with patients like on a day-to-day basis. There's a lot of confusion and lack of knowledge, and a lot of discussions also with Medact and other organisations that are part of the entitlement working group, and they include Amnesty and Maternity Action, things like that, felt that led to sort of a disempowerment and a lack of ownership of clinicians, sort of on the part of clinicians, who obviously have a duty of care, and so that neglected duty of care is what's partly damaging. Now, in most cases, the lack of knowledge leads to over-treatment of refugees who are not, or migrants who are, strictly speaking, probably not entitled to care. But with changing public opinion and a lot more sort of the rules becoming stricter and a lot of sort of top-down influences on the part of budgets and so, I think it's really important to empower doctors by teaching them. So this was set up as a workshop at UCL, where I ran this for the 5th year students who do a lot of who do their obs and gynae and their psychiatry, and you guys missed out because it was the other year, and it's now actually become part of the core UCL curriculum. So, and this is now, and the aim is, with the help of Doctors of the World, who currently haven't approved this set of slides yet, but I'm sure will at some point, with modifications, to be rolled out to other medical schools as well. So that's a brief introduction. So what I'm going to do basically today is run through that workshop. So both for your sort of educational purposes, but I don't want to be too patronising about that, but also any input on how to make it more useful, more interesting, more engaging at the end would be useful, because this is supposed to be a sort of trial run pilot for how to teach medical students, as well as junior doctors in hospitals, about this issue. Okay, so these are the objectives, nice behavioural objectives, so that people know what they can get out of it. So the pointer's not really working. Explain who's entitled, list which NHS services are chargeable, which ones are exempt, and then 2 specific points talking about urgent and immediately necessary care, and then the case of victims of trafficking and asylum seekers who are unable to return home. Those are 2 special cases. So I have a little quiz at the beginning. Now, sadly, there's no handouts, but I would like to go through, I'd like you to spend maybe not 5 minutes, but a few minutes discussing with the person next to you these questions. And I really want you to engage with the questions and have a little think about going through them. So feel free to have a look. I think I'm not going to spend too much more time because this is. I'm sure you're all incredibly confident about the answers. Very unsatisfyingly, I'm not going to go through them right now. So this is part of the teaching most. I'll go through it at the end again when you'll get a chance to relook at your answers at the end of when I talk to you. But the point is, the one thing I will say about this now is that there's a lot of terminology and a lot of terminology that's not particularly intuitive because it's all legal and politics. So it might be intuitive to non-medical professionals, but it's definitely there's a lot, and terminology changes a lot. So for example, until this week, 6 was different for me. I was a bit late with the update, but the UN actually changed 6 over recent sort of months. So I was told actually no, I should put a different word there. So these things change. It's fluid and it's complicated, and very many similar words are used for the same thing. So this is now specifically not just about terminology, and don't worry about writing things down furiously. You're more than welcome to have slides afterwards. My email address is plastered all over the slide, so I can send it to you. Please have another few minutes to go through these. This is specifically about asylum seeker and migrant access to healthcare. So just have another discussion with the person next to you.
So my understanding is that asylum seeker if you went to the but I don't know if that's true.
So can I just join up?
Yeah. I thought it was
have applied for asylum once, and I don't know if you know how this all works. You apply once, and they sort of blanket refusal of 90%. Just for no real policy, and you apply again, and then they start accepting you. People they get failed the second attempt, and then some of them are eligible for accommodation. I think we're in that situation. But if I start right, they're not eligible for I knew that, so I probably shouldn't have done that. Yeah, I don't know, I'm not sure about it. It's complicated, it's really complicated. It's also changed now. I know that it's changed, but I don't know how, because now citizens have the right to register, well, they don't have to take on courts, and there have been cases. Without really situations, people have started rejecting acceleration. Yeah.
You must have the discretion to reject.
Has everyone has everyone sort of read most of them?
NHS.
So,
the HIV still would be NHS.
I'm not someone who writes MCQs, so they're probably not phrased in the best in the best way, but I tried to make them applicable to some of the complexities and the things that I struggled with when I was trying to come to terms with all of these regulations. And they're not particularly intuitive, and in fact, as you'll see, some of them are plain silly the way they've been designed. So, for those of you who are medical students, think forward. It's probably not very far away if you've got any clinical experience right now. You're going to be an F1 or an F2 within the next at least 2 to 3 years. For those of you who are already junior doctors, think of your next night shift at A&E. And this is to make you realise that it really is often a very direct interaction, and all of these rules can be incredibly clinically relevant when you're working in A&E. So you asked to clerk in a lady called Aisha. She's 77 years old, and she's from Somalia. She speaks very little English. You know this from the brief triage history. And your impression when you sort of guide her into A&E is that she's very anxious. She's even quite scared. But she comes with you. You speak with your hands and the little sort of English that she has. And you make out that she's been in the UK for 2 months. She has applied for asylum. And her claim is currently being processed. So, what NHS services is she entitled to? Okay, one person at a time. Emergency care. Anything else? Urgent. So, similar. Any other offers?
GP.
Okay, cool. So she's entitled to all of those. In fact, she has applied for asylum. She has come to the UK, and I think it happens in Croydon, and she has immediately said, I'm seeking asylum, I'm here as a refugee, which means that she's entitled to everything on the same basis as any other UK resident. So, someone vigorously shaking their head. Quite sure that's right. So anyone who comes here who either has an outstanding application or an approved application has completely the same rights as anyone else. You're allowed to appeal once, so you're allowed to apply twice, which has changed sort of over the last 5 years. You used to be able to appeal, and usually that then, if you then get refugee status, it'll be recognised. I mean, when you get asylum, it'll be recognised as refugee status by the UN. That then has a whole load of responsibilities for the UK government, as it should be, and you get granted 5 years of leave to remain. And after that, you can then apply for indefinite leave to remain. I'm using these words not to be all fancy, but because those are the words that are often used. Those are the official terms, just so that you become familiar with those as well. So asylum seekers, either with outstanding applications or approved asylum status, are entitled to care on the same basis. So a few weeks later, you're still in A&E, and you're on call again, and you're working shift in A&E, and Aisha comes in again. You've got a relationship with her, so she approaches you to see to see her, and she's with Adama, her 36-year-old daughter. Adama's English is really quite good, definitely compared to her mother's, so she's probably been here for a bit longer. And she tells you that she's got a bloody cough, a fever, and night sweats. She's had this for the last few weeks. And she also tells you that she's got diabetes, which she manages by her diet. So, seeing as this is aimed at medical professionals and medical students in their introductory week, I've got a bit of a spot diagnosis here, but it's probably not greatly projected. But you find these things on her legs, they're sort of dyspigmented lesions. Any of the medical students, not the doctors, do the spot diagnosis. What's the story? So the bloody fever and the weight loss is TB. What are the spots on the leg? You guys, you're in 5th year, you should know, we did this last year. Jonathan Cartledge. This is Kaposi sarcoma, HHV8, very common in HIV. Sorry to pick on you. So she's got HIV, which fits with the TB. And the reason I picked this is because the burden of disease of TB and HIV in these groups is much, much greater. And also the co-infection rate of those two diseases is very high. So people with TB have a lot of HIV and vice versa. So that's just a medical aside. So she's got TB on the background of HIV, and she's got some diabetes. So you ask her, not an unreasonable question, whether she takes any regular medication, just as part of your clerking. She goes really pale and quiet. You reassure her that your conversation is completely confidential, and that nothing she tells you need go beyond, the room that you're in. She tells you she did try to register with a GP, but they asked her for her passport and proof of address. She doesn't have either, and sort of the confrontation with the fact that she doesn't have those made her quite scared. So that's quite a common thing, and there's quite a lot of fear. There's been some research by MSF in Sweden that's quite old, but there's been also more recent studies about how a lot of irregular migrants or undocumented migrants, for whatever reason they're here, but even amongst regular migrants or people who have approved visas here, there's a lot of fear that healthcare services are in some way linked to immigration services. And that they're and in some countries that may be true. And in fact, the UKBA happily writes to GPs to try and get details from undocumented migrants, and there's evidence for that. So obviously most doctors wouldn't respond to that, but it's not an illegitimate fear, and it's a very common fear. So I just want you to think about what her immigration status is going to be, based on the information you have. You obviously may not have the whole story. What's her immigration status? Exactly. So she doesn't have any documents. She may be here irregularly. She may not. You don't know. But she doesn't have the documents. And undocumented migrants are often used as illegal, and often they are, or irregular as they're called now. But it's not completely the same thing. That makes sense? If any questions at any point, just shout it out. Is she entitled to primary care? Should she have been able to register with that GP? Go ahead, you were chatting before when we were doing spot diagnosis.
Yeah, GPs, this policy of you need an address to register at this GP is a GP policy, it's not a legal policy.
Absolutely, completely, I'm very happy to hear that. I'm glad that misconception doesn't exist. So, it's practical for GPs. I don't want to create this massive dichotomy of evil GPs and evil overseas visitor managers. I don't think it's constructive. Ultimately, we're all trying to do similar, if not the same thing. It is practical for a GP to ask for your address. They have a catchment area, they have incredibly full lists. Sure, they have quite nice contracts for those really long lists, but they do work very hard, so they have to restrict at some level, but it should never be on the basis of passport at least. But and the other thing is that I should say is that don't blame the receptionist either, because very often they work with computer systems that just will not allow them to register patients on their books unless they've actually scanned in a copy of the passport. So, I don't want you to come away thinking, oh, evil receptionists, evil GPs. Absolutely not the case. But as we all know, this is something that's part of most GP registration and a problem for people like Adam. So she's probably undocumented migrant. I will come on to that. I'll come on to that. You've read my mind. You've read my mind. So I'll come on to that in a minute. So practices are not required to check the identity, and this is literally lifted from either the Department of Health or the BMA. So no, actually this is from the Department of Health. And overseas primary care, there's no restrictions. There was a lot of talk about having some restrictions when the regulations were introduced. There was a consultation about it. That was never published and all this sort of nonsense, but it was never introduced. Okay, so and I know that when I did at UCL, when I did my GP rotation last year, very, very senior people in the primary care department told me that there was only one person that a GP couldn't register, and it was an undocumented migrant. And this was a very senior person at a very good medical school, and I had to have a massive argument with him and tell him that actually send him a whole load of documentation from the Department of Health that he was wrong. So there is a huge misconception about this. Okay, primary care completely unaffected. Fine. What did I say? Oh yeah. What might the GP be accused of if he refuses to register, Adam?
Negligence.
Definitely. A lot of people say that in response to this question. I've got my answer here already. Because actually, there is a sort of philosophical... I don't know how strictly enforced or how legally defined it is, but GPs, strictly speaking, have a duty of care for people that live within their... I think definitely the GMC has probably got some guidance on it, that GPs have a duty of care. So the GP walking around the street in their catchment area has a duty of care to the person lying there needing emergency services, whereas doctors in the UK don't generally have a duty of care to every person. So if I walk around here, and it would be ethically right for me to help them, but it's not. I mean, these things are always more fluid and things. So negligence is one thing, discrimination is another. What do you want to say?
Yeah, just one question. If they're treated by the doctors, do they just pay the costs for it, or how do they, like, the doctors have costs when they treat patients, and if they're not registered, how do they get their money for the services that they provide?
If they're not registered, how do you mean?
How do the doctors get money for the services that they provide? Do they do it just voluntarily, or?
In which
For
situation?
the undocumented migrants.
Oh, for the undocumented migrant, it's part of the budget. So whatever budget a royal, what is it called?
They were enumerated because they wouldn't be able to go on the PCT or the CCG register to be to count as a practice, one of the practice population of patients. So strictly speaking, the GPs would be just doing it
Oh, no, but
budget with the existing population of patients. Because to register as an NHS patient, you need an NHS number, and in order to get that, you do need the details of your passport.
But those are all administrative things, and actually there are ways around getting an NHS number. You don't necessarily. I mean, the Project London, for example, in East London, helps with writing letters and saying actually this person doesn't have a strict proof of address. The Thames water bill doesn't come to their flat, but they are ordinarily resident within this area. They have an asylum status, or they're an undocumented migrant. And I mean, this is a point that someone else was alluding to as well, which is that this doesn't just affect undocumented migrants. Another big population group that would be affected by this would be homeless people. I mean, you don't hear, there's no big movement to get homeless people to, not be allowed to register for GP practices, but they get.
There has been very much. I mean, there are a number of practices in London specifically with homeless people wanting to join those practices.
I don't know. I know there's a problem. I know
I
there's a problem. What I'm trying to say is that never mind. Anyway, these rules totally affect homeless people. They also don't just affect homeless people. They affect European. They affect students classically who don't have fixed addresses. They affect your grandmother who is, or maybe not your grandmother, but an elderly lady with dementia in a care home who doesn't have a regular carer, who's brought into A&E with a carer who doesn't know her, and who can't advocate for herself. So it affects a huge number of other people as well.
So the one thing I just don't understand is how an undocumented migrant gets the NHS number.
So actually, the technicalities of that I don't know, but I
point, isn't it? Because without the NHS number, you cannot access care. So
go ahead.
One of the GP practices one of the Bristol practices just registers people without their address. And just gives, I don't know if they get an NHS number or whatever, but they don't.
I mean,
I know they get temporary numbers, but they have an NHS number.
I mean, I don't know how they physically get the NHS number, but I know that they do, and Project London helps with that, as do many other organisations. There are huge GP practices in Newham where the population of migrants and undocumented migrants is significant. So it's definitely possible. I mean, this is part of this problem of where we're dealing with computer systems or other sorts of systems that are just very restrictive, but that actually in law or in terms of Department of Health guidance, there are no restrictions to primary care. The important point to mention at this point is that the population that we're talking about are of refugees who either have asylum status or undocumented migrants who've come here. It's a relatively small population. They are often quite young because they've been healthy enough to travel here, and they often have quite a low burden of disease. I mean, that's what studies in the past have shown, and they do present to healthcare services, and when they do, they can have very complex psychological, psychiatric, and other healthcare needs. But I'm not talking about health tourists, and I'm not talking about those categories. So that's a very different thing. We've digressed slightly, but that's good. So the GP might be accused of discrimination, and this is an important an important point. There was an anecdotal story that went around, and I cannot remember the source. I received it second-hand, but maybe you've heard it as well and can tell me the source. There was a story that when these rules were first brought in UCH, in secondary care, that at UCH, a way of trying to find out whether people were ordinarily resident, they obviously couldn't ask everyone coming into clinic. So they would screen people based on their, like, how foreign their surname sounded. Now, whether that story's true or not, but it just shows you that this is a hugely difficult area. And I think it did actually happen.
Routinely,
yeah.
The overseas officer in a hospital will go through the medical provisions list, look at surnames and their address, and that's what they're employed to do, be detectives. So, you know, you would develop, as do doctors, ways of sort of, you know, hiding your patients sometimes from those people. Scale hospitals.
Yeah.
And actually, sorry to
No.
digress further, but the discrimination thing is a really useful argument for you as a doctor to fight for your patients, and I've done it many times with the kind of, you know, people and management people that come around and say,
and there are two things I'd like to say to that. One is that that is a perfect example of taking ownership and as a clinician, and to defend that duty of care that you feel towards, or that you have towards that patient, which is one of the main things of why we want to transmit that knowledge. The other point in parallel, which is what I was talking about, don't call all these GPs evil GPs or their receptionists evil GPs, is that I think that although we have in the past sort of caricatured overseas visitors officers or management as such as difficult or uncooperative or on the other side of the argument, they are doing their job, and I know that they're not in this, you know, they don't, or, you know, we don't always agree, but I think it is unhelpful to label them as the enemy, and I think that actually, you know, there might be a benefit in working together and trying to change these rules. That might be a bit of a naive attitude. I think we need to move on, although I do love the discussion. So this is actually, again, lifted directly from the Department of Health guidance. So it's very clear that GPs have discretion to register, but they can't do so on the basis of the things listed. There will be many more points for discussion. So this is a bit more of a general question. If the GP had been completely aware of the rules and had managed to get an NHS number miraculously, I know it's hard, but it has to be possible, because I know people who properly register undocumented migrants. What barriers might she have experienced? Sort of many suggestions welcome. Language is a big one. Yep, definitely.
Knowing the health system.
Exactly.
Cultural, being treated by a male GP.
Completely. Cultural, different approaches to
Fear and intimidation. I mean, like, you look at the kind of detention centres where a lot of people arrive, and frankly, access to healthcare is either non-existent or sometimes abusive.
So that's actually an interesting point, because detention centres, I'm not saying the healthcare there is good, I'm fully aware of medical justice, but refugees and undocumented migrants in detention centres are officially detained, and therefore as prisoners are actually legally entitled to probably better healthcare. Like, I'm not theoretically. But it's an interesting difference in that if you are an asylum seeker, if you are a refused asylum seeker who cannot return home, if you're an undocumented migrant here, then you are entitled to less than if you're an undocumented migrant in a detention centre. But those are subtleties and complexities that sort of are beyond this.
Just as somebody said, lack of knowledge, it's really important, because in other European countries, I come from Germany, it's totally different. Like, undocumented migrants don't have the access to healthcare services as they have here. So if they would go to a doctor and are not documented, it would be really, really dangerous for them. So this is when they come to the UK, probably they've crossed some other European countries where the laws are just different.
Yeah. So and I'm not even dealing with knowledge amongst the populations affected. I'm just dealing with knowledge amongst healthcare professionals who are treating these patients. And there's a really interesting report, if anyone's interested, slightly out of date, but Médecins du Monde, or Doctors of the World, have written a very interesting comparative report about European access regulations. You're nodding? You're involved, or?
No, I'm not.
MDM, or Doctors of the World. And if you email me, I can send it to you. I've got it on my computer. My email will be at the end of the thing. But it's just look up comparison access regulations Europe. And Spain, for example, has relatively restrictive, and then Sweden. And it was all different and really interesting. So these are just some of them. No way is this a comprehensive list. Unaware of entitlement. So this is sort of what I think of as the patient experience, so language barrier, fear of being reported, unfamiliar with the NHS. And then we all have assumptions, we all have prejudice. I mean, I clearly have an opinion, and you know, it influences your practice however objective you try to be. So all these things will influence and will create barriers which you are aware of or unaware of. Okay, so back to Adama. She's not got any documents. We don't quite know what her status is. We know that she's allowed to have GP like primary care services. What NHS hospital services, or what other NHS services, what services may she be charged for?
Elective hospital procedures.
Yep. And she probably prescriptions, depend what sort of, yeah.
Maternity care?
Yeah, she definitely will be charged for maternity care. There will be a subtle point about that, but yes, maternity care.
Gun, sexuality.
Charged. She will be charged. Okay, so let's go through it a bit more systematically. So she's an overseas visitor in terms of the NHS. Now there are multiple different definitions flying about around this. The Department of Health the UK government defines it as not ordinarily resident, which they then start defining as, well, if you haven't lived here for a certain amount of time, and then they qualify that time, and they say, well, you know, if you're for example an English citizen who is usually based in Spain but comes back only for holidays, that means you're not ordinarily resident if you don't come back every year. So it's very complex, and it's also not fixed. So people who've been here for less than 6 months but who plan to stay here legally can be considered ordinarily residents. So a student who might come to study medicine here from Europe, who will be here for the foreseeable future, might be considered ordinarily resident in a legal in legal terms. Often you see posters around hospitals that say, question this person's entitlement to care if they haven't lived here for 12 months. 12 months is a figure that's bandied about a lot. There's no strict definition of this is when you become non-ordinarily resident or ordinarily resident. If you have leave to remain in any form, or if you're an asylum seeker, then you don't qualify as an overseas visitor. Okay? So she does, because she's an undocumented migrant, as far as we know. And they can be charged for most hospital services. So anything beyond A&E, they can be charged for. It excludes anything in A&E and emergency services. Family planning is exempt from charging. The treatment of certain communicable diseases, and there's a little bit of an aside to that in a minute. Treatment of sexually transmitted infections are exempt, and compulsory mental health treatment is exempt. So these are mostly sort of public health and human rights arguments. We're not going to leave anyone in the UK lying by the side of the road, you know, bleeding to death. That it does not fit with the UK's idea of its own sort of respect for human rights. And also public health. We're not going to let people with raging TB like walk around without any treatment, not someone with a raging psychosis walk around. So those are sort of the ideas behind it from the government. Yes?
Just a very quick question. So if you have an emergency, like you're in a car crash, does your whole hospital stay count as an emergency service? Or once they've got you through A&E and you've had your leg fixed, but you're in hospital for another 6 weeks, are you expected to pay for the other?
So this is complicated, and I think it will depend, like so much in medicine, on your local trust policy and guidelines. So it depends on the local overseas visitor officer, and different overseas visitor officers will be more or less vigilant and more or less, but I have heard stories of people who have an emergency admission they need, and they will not be charged for the urgent, and they will not be charged for anything within A&E, but then later on they have diabetes on the background and they needed some extra management for that, and then they will be charged for that separately. But it will vary. It will vary on your trust.
And it's decided on by the overseas officer.
They have a huge amount of influence, but there'll be some.
And then if you're not happy about what they've decided as a doctor looking after someone, is there anyone above them that you can escalate to?
I'm not a doctor, so I've never been in that situation. I imagine there is, and the whole point of this talk is that there is, and we'll come on to that in a little, which is why I'm going to move on. You can decide. There are two types of treatment which may be charged but can never be delayed, and you can decide whether something fits those. So, but the flow of the. So, you had.
No, I've been in that situation. In fact, it was the Malaysian husband of a nurse working in our hospital who was visiting and who unfortunately developed a very severe acute vasculitis, having never had anything wrong with him. He was exempt from the treatment he received in A&E, and then the hospital tried to charge him for literally everything onwards from there. And the way we managed to battle out of this is using an ethical and moral argument with the hospital managers and hospital lawyers. And that's really the only argument I've ever found that has worked.
And this is the thing. So you'll then have to just deal with whatever structures there are within your hospital that I just don't have any experience of. The problem with ethical and moral arguments, and which this talk is quite dry of, is that I find they tend not to work, at least with policymakers. They just aren't that interested in human rights. They are much more interested in does this make financial sense, does this make public health sense, which is, and also that the reason for this talk is that I'm giving it to, in this audience I have a selected group of people who have come to the Medact forum. When I teach medical students, it's a huge range of people and there will be different opinions. I just want to make them aware of the rules, and then they can decide how to take ownership of those rules. So the aside about communicable diseases is that I think the story was that they literally just picked the list of notifiable diseases and then put those as the exempt communicable diseases, which excluded HIV, because HIV is not strictly speaking a communicable disease. It's not notifiable, it's obviously a communicable disease. It's not notifiable because of the confidentiality arrangement. So there was some strange reason, I mean, please correct me if that's not the reason, why HIV was exempt, but it took almost 6 years to make sure that you couldn't just be tested for HIV, but actually could get treatment as well. And this makes no public health sense to exclude TB but not exclude HIV. So this was a big irony, and the Terence Higgins Trust and National AIDS Trust did huge amounts of campaigning. This is a big success story from that campaigning. I need to move on. So you present Adam to your registrar on call. You decide she needs admission, she's quite unwell. Is she going to be charged for this admission? I'm going to move on quite quickly because we've had quite a bit of debate about this already. She might be. So she has the TB and the HIV, and those might be exempt because she might not be charged at all for those because they're communicable diseases. But she has diabetes as well, so if you've got a very on it overseas visitor manager who decides to bill her just for that might happen at your trust. And yeah, anyway, so now we move on to the bits of treatment that can never be delayed, but you may get a bill for. So if Adam had presented with reduced consciousness, so she's got this due to ketoacidosis because of her diabetes, but none of the other symptoms. She hasn't got HIV, she hasn't got TB. How would this have affected her treatment and how much she would have had to pay for?
She wouldn't have to pay for the initial resuscitation, whatever the first day or two, but then if she needs to go on a certain insulin regimen, then she'd have to pay for that.
Exactly. So this is just a way of getting on to urgent and immediately necessary, and this becomes quite confusing, but this is also the point at which doctors have the most power to say, actually, this is my decision, this person needs this treatment, and whether the overseas visitor manager will charge them later is not currently relevant. So urgent treatment, it may not be necessary right now in order to save that person's life, but if you don't give that treatment, then they will be in a life-threatening situation, so you cannot therefore delay it. So this is the renal failure patient who had chronic renal failure for a long time, and you know that they're going to need dialysis or they're going to need a transplant, or the complex medical decision making of that I'm not going to go into because I don't know, but you're not going to delay them receiving that dialysis until they come in with a potassium of like 8. Okay, so you go and treat them before that. And there are stories of where doctors have completely misunderstood this, and I know that I know stories from my year group where medical students came up to me during they told me later on that during their renal firm there had been a doctor who'd said, look, I'm really sorry, I can't treat you. You've got like bizarre U's and E's and your creatinine is quite high, and I know you're going to need dialysis at some point, but until you come back with like really bad renal function and you need dialysis right then and there, can't do anything. And he felt horrible about it, but he clearly completely misunderstood that actually he could have gone and said. So this is another reason why this education is important. Immediately necessary treatment is self-explanatory. It's necessary then and there. So the problem is these things are chargeable. So patients can later on get a bill for them, but while you're finding out whether they're entitled to care or whether they can pay, it can't be delayed. So it's no situation where you're waiting for a credit card to go through or something like that.
What happens if they can't pay?
So this is the big problem with this. So many of this money is completely non-recoverable, which is why it's a bit ironic that this tiny population relatively small population of people who are seeking this healthcare are being charged and scared with bills that are often quite big, especially when we come on to antenatal care. They're really quite huge bills. They're scared with those bills that often deters them from seeking access in the future. The second important point is that the NHS, the government now, if you have any debt with the NHS, that significantly hampers your future applications for visa or asylum, and that's likely to get more problematic with recent developments and the social care bill that's going through right now. And often, with all good intentions, people will be informed of this. Oh, you're here for your booking. You're here for your booking appointment. I'm really sorry, I can't delay this. I won't delay this antenatal care, but I will have to tell you that it's this kind of bill, £6,000, whatever it is, £10,000 to have all your scans. And also, I should tell you that you may in the future have problems applying for a visa. Well, if you're a vulnerable lady who's pregnant and who wants to apply for asylum maybe in the future or apply for another visa, then that's going to deter you from going through with that antenatal treatment. So I think I'm moving on to that in a minute. This is one of the most important points from my entire talk. It's clinicians who decide what's urgent and immediately necessary. And sure, overseas visitors officers may actually be helpful in letting you know when this person may or may not go home, or what their immigration status is. They've got access to a lot more information about that, but you, as a clinician, decide whether something is urgent and immediately necessary. And it's that ownership of that decision that's why I'm doing these workshops. So she's discharged, she's doing much better, she has some due follow-ups, she goes to HIV clinic, and you check on her before she leaves the hospital because you've got a relationship with her, and you just remind her that she's entitled to free primary care, and that it would really be very good if she goes and registers with a GP, because it could help her out in many ways. She says that she's really scared to go back and advocate for herself, and I mean, with the complicated navigation of NHS numbers, I'm sure she's rightfully scared and quite wary of going back to the GP. So what do you do? Actually, this is a tiny little slide of why this, not just a fear of how difficult it is to get an NHS number without an address, but actually probably about 5 years ago, and it very, very likely goes on still, we found out that the UKVA wrote to what were at the time primary care trusts, and they had these very scary letters being like, "Dear doctor, we have heard that some undocumented migrants have registered on your list. If you do not give us their addresses, you may be complicit in an immigration crime. Please give us their..." And I can't remember the literal words, but it was along those lines. Now, the medical professionals in this room and the medical students will know that confidentiality should never be broken unless the patient is at risk, or their family is at risk, or there's a communicable disease, and you should always tell them before you do it, etc. So the letter was horrific, unlawful, but it reflects the really well-founded fear that people have of going to GPs. Anyway, brief little point, if you do have someone who's struggling to register with a GP that you meet, send them to Project London. Doctors of the World run a clinic that is, I hear, expanding in East London, in Bethnal Green. It's not a parallel GP medical service, but they do provide some basic medical care, and I've been told that the number of doctors and nurses that work there is actually expanding. The other thing they do is they have a whole load of support workers who love new volunteers, so do write to them if you want to volunteer for them, who call up GPs and say, look, we've got this patient, we really should make you aware that actually, you should allow them to register because of these and these reasons, and they advocate for patients who are unable to advocate for themselves. So they do an amazing thing. Also consider working for them if you're already a doctor. They probably already seen doctors. At the moment, Doctors of the World is very, very thinly stretched because of all their involvement with the Ebola crisis, so any extra help, I'm sure, is welcome. And they do great stuff. So this is their flyer. Project London, you'll find it. So months later, you were an F2 on A&E, but you're now an F2 on obstetrics and gynecology. And it's a Saturday afternoon, which makes you one of the sort of few people on the ward. And Aisha brings in her daughter, who is now 38 weeks pregnant, and she's got a blood pressure of 119 over 110. For people who haven't done obstetrics and gynecology, not very good news. She's not registered with a GP, she was too scared, so she's had absolutely no antenatal care. She's otherwise well, and sort of somehow her CD4 count has been great, her viral load was undetectable before she got pregnant. So let's just not ignore the gum part. Is Adama entitled to free antenatal care? We've sort of touched on it already, so is anyone brave enough to volunteer?
Yes.
She's entitled to free antenatal care.
You can argue the delayed, the delayed charge was is that it's not life-threatening now, but it will become life-threatening when she's at risk of
Absolutely. And in fact, this is one of the few things where it's not a clinician decision, because actually the Department of Health has classified antenatal care as immediately necessary. And it makes sense because you're dealing with really important scans that determine whether or not the fetus is healthy, and it's a very core part of screening and healthcare and disease prevention in this country. Sorry, I'm slightly losing my train of thought. However, it's not free. It's actually chargeable, but it can never be delayed. And this is the scenario, so this is what I've just said. So this is the scenario where people, I don't know if you can even see this, where people, and not always with malicious intent, but where people get presented with bills and get told, look, this is your booking appointment, but you have these and these scans, and you may well get a bill either at the end or as we go along, which we won't delay your treatment, but you may get a bill. So that's incredibly scary, and when you're 8 weeks pregnant, you may then not come back. One of the other big problems with antenatal care in terms of barriers is that the UK and European countries are exceptional in the level and the intensity of which we do antenatal screening, and that's not common at all anywhere else. So that's a big difference with why women often don't present during the very early stage of pregnancy. You had a question?
Obviously there's a conflict for a doctor who has to explain to a patient that they're going to have to pay. Is there a duty legally for the doctor to explain that before? And if not, is it better not to explain that and then that be a justification for them not paying in the future? I'm trying to think about...
Yeah, no, the practicalities are really complicated. I actually don't think doctors... I mean, I don't know if you've ever... I mean, you've been in antenatal clinics, because I know you're in my old years. When I've been in antenatal clinics, I've never seen doctors deal with this administrative stuff. They're hectic clinics. It's not them to deal with it. It might be the receptionist or the administrators who'll be dealing with this kind of stuff. And you could argue that there is some sort of responsibility to disclose. But then if you're thinking about patient best interest, which is what is the overarching ethical principle of how we all practice medicine, if that's going to mean that they're then going to not come to this routine appointments, then that's not in their best interest. But it's incredibly complicated, and I don't want to give you guidance now on how to do that, and what to do. There may be guidance out there, but seeing as the guidance is very thin on this entire issue, I doubt there will be guidance on that.
It just strikes me that you can fight this quite easily, like as an individual.
Well, none of these bills are actually recoverable very often. And until quite recently, actually, the NHS employed debt collectors for some of these people, but I think that's been stopped now, at least in certain situations.
I think it's the same point. I've worked in A&E, I've worked in Slough, and I've seen lots of sort of international patients. I've never heard of an overseas visitor officer. I've never had to sort of confront this issue, and I just worry that because there's this gatekeeper kind of function of the sector.
They might not even ever come to you.
That this never comes to you, and you know, do I bring it up to every patient, or is it happening without my knowledge?
I think so. I actually think if once your eyes are open to this, you start picking up how often it happens. So I just on UCH on the ward, if you go to AMU, the acute medical unit, on their wards, you go through some notes, and very, very often there will be a set of notes which has a blank A4 which says the overseas visitor manager or officer, however they're called, has been to see this patient pending proof of some sort of agreement with the country that they're from, or proof of ability to pay, or proof of their immigration status. Please stop all treatment. And no, it's in their sheets. And I don't want to demonise these people, because I think it's really easy for us doctors to be like, oh, management, oh, overseas visitors officers. They do a job, and they've been told to do a job based on the rules that exist, and whether we agree with those rules is up to you. I think it's very easy to demonise them. The important point is as a clinician, it is up to you to say, that is fine, I think this treatment is urgent, or that is fine, but I think this case is particularly harrowing, and then I'm going to call the lawyer that I know, called, in this case, Adam Hunt, who's great, who is going to argue this case, who's also going to have a benefit from that, because more cases that are argued in that way and that go to court will then, but try and find the refugee or the undocumented migrant that's happy for that to happen. So that's a whole other issue that we're going on to. I'm short of time. I just want to quickly finish off with 2 points. So it becomes clear that she was trafficked. I mean, if people want to actually leave, then you're up to now. I'm almost done. No one leaving? Cool. So during her stay, it becomes clear that she was trafficked. Does this change anything? Legally, like morally, obviously, it changes things.
No.
So legally, it does actually. It didn't originally, but now it does. So people who are exempt, who are who are trafficked here, are exempt from charging. She might still go to a detention centre if that becomes clear. And I've seen people come into A&E who were trafficked here, who were immediately shipped to detention centres. But she's got a lot more. She's got a lot more recourse, and she is actually legally entitled to care on the same basis as UK citizens. The other point is that there are a small group of people who fail applications of asylum, so they have their 2 appeals, and who then can't return home. Now, these are scenarios where their children or the UK doesn't deport to their countries, and the UK does refuse certain asylum applications from people from those countries, but doesn't deport to those countries. So these people are in some sort of limbo where you're not allowed to work here, you don't have any legal status here, you're not allowed to do anything, you can't pay tax, you can't do anything, and you're not entitled to healthcare. Well, you weren't. Now you recently, so I think this was in 2009,